Good evening. Thank you very much for attending this Belgian Society webinar on vitiligo. First of all, I would already thank our speakers, of course, but also our sponsors, without whom the organization of this webinar would not be possible. With the emergence of new immunomodulatory agents and therapies, vitiligo is a disease which is undergoing a very important evolution at therapeutic level mainly. Tonight we are really happy to welcome three expert speakers on the subject of vitiligo. First of all, Professor Reinhart Speeckaert and Nanja van Geel from the University Hospital of Gent. I think that everybody knows their experience in the field of vitiligo and pigmentary disorders. Then Professor Wolkerstorfer from the Dermatology Department of the University of Amsterdam. He studied in Vienna and obtained a PhD in Rotterdam, and is particularly interested and focused for his clinical practice, but also on research projects on pigmented disorders. But let's start with Professor Speeckaert, who will talk about vitiligo treatment, why they work or don't work.
Thank you. Indeed, I'm going to talk about pathogenesis and a bit more why treatments do or don't work. Here are my conflicts of interest. So, if we look at the pathophysiology of vitiligo, we first have to know that also healthy people have cytotoxic T cells against melanocytes in their blood. So we all have them, but normally they are quiet, they are inactive. Because that's how a good immune system works. The defense is ready to attack if necessary, but in most cases it's not necessary to attack. Now we know how we can make them active. If we look at melanoma patients, when we give immune checkpoint inhibitors, we can induce vitiligo in a lot of patients. So that's quite interesting from a pathogenic perspective. So it's not abnormal to have immune cells against melanocytes, but normally they should be quiet and not active. This is a study that we performed a couple of years ago together with the University of Amsterdam. And there we looked at pictures and we were asked to score whether it was a melanoma-associated leukoderma or whether it was vitiligo. And in fact, for us, it was not possible to make the differentiation. So the point here is not that you have a lot of melanoma in vitiligo, in fact quite the opposite, but from a pathogenic perspective the immune defense is there and it's just a bit too active in patients with autoimmune diseases and in particular in vitiligo. So our immune system wants to control the melanocytes, and we can say that halo nevi, where we have an immune destruction just of the nevoid melanocytes, is a good immune response. We don't want it to be overactive, because then we have vitiligo, but we also don't want to induce tolerance, because otherwise this can lead to melanoma. So we have a balance there that we have to search in our treatment. So, as you may know, vitiligo patients have a decreased risk of melanoma, and also interestingly of non-melanoma skin cancer. This fact has been proved in several studies. The protective effect ranges a bit, but there's quite a strong effect for reduced risk of skin cancer. So melanoma, you can understand this, but also non-melanoma skin cancer. And this was a meta-analysis where you see that most studies point to a decreased risk of basal cell and squamous cell carcinoma. So how can we explain this? We have this increased immune surveillance, so our immune system is stronger. It is less regulated, so if it's active, it stays active for quite a while. And also there is something that is called the bystander lysis effect. That means if a melanocyte is killed, the surrounding keratinocytes are also destroyed. And interestingly, also in basal cell carcinoma, you can find melanocytes. So all these facts can explain why there is a decreased risk of squamous and in particular basal cell carcinoma. There are also some non-immune related factors like apoptosis markers and so on, which also contribute to this decreased risk of skin cancer. So if we look at these immune checkpoint inhibitors, these are results of our lab of Arno Belpere. And there you can see, if we compare to healthy controls, that these immune checkpoints are downregulated. So it's the same in melanoma patients. You give them an immune checkpoint inhibitors, it's downregulated, so you get vitiligo. But if you look at vitiligo patients, these immune checkpoint inhibitors are also downregulated. So it's exactly almost the same thing that we see in melanoma-associated leukoderma. Also, on a genetic level, all the genes that are associated with skin cancer are inversely related to vitiligo. So it all points down to a nice summary. There we have this immune balance, which is just a bit too protective in vitiligo patients. So we have this balance, and for our treatment, that's quite important. So if we have vitiligo patients, the balance is more towards autoimmunity. So then we can get vitiligo, but it also offers a good antiviral and anti-tumoral protection. If we give a treatment, of course, we want to have a nice balance, but we don't want to give a treatment that is too strong, because otherwise we can have problems with viral infections and also cancer. So this is a real challenge for our treatment, to find really a good balance and not to overtreat our patients. So if we go a bit deeper into the pathogenesis, so we have these melanocyte-specific T cells, which are drawn towards the epidermis via chemokines, and especially CXCL9 and CXCL10 are important there. So these immune cells, they will migrate towards the skin, they will proliferate, and then they will try to destroy the melanocytes. So one important thing to point out, when a melanocyte is destroyed, it takes about 6 weeks before the skin gets white. So if you start the treatment and the patient still notices a progression, that's normal, because it takes about 6 weeks before the skin gets white when the melanocyte is destroyed. And interestingly, the hairs are spared, especially in non-segmental vitiligo, for quite a while. And it has been discovered why. Again, these immune checkpoints, these are upregulated around the hair follicle, and there form a shield where the immune system is more difficult to become active, and so there is our reservoir of melanocyte stem cells. And we know when we try to repigment, we see these small dots around the hairs coming up, and then the skin gets repigmented. So finally, the antigen-presenting cells, the dendritic cells, will take up the melanocyte antigens, present them in the lymph nodes, and then we will get this memory. And these memory T cells, well, they are quite a problem, of course, because that causes the disease to recur at the same place. At the moment, we have only 2 options to handle these. We can treat very early, and so prevent the memory T cells to settle into the skin, or we can treat for quite a while. So if we have a full repigmentation, we will treat for at least 6 months to maintain this repigmentation and hope that these memory T cells will be gone then. Of course, now we have this JAK inhibitors, and we have different type of JAK inhibitors, JAK1, 2, 3, and TYK2. They all will diminish different cytokines. The main cytokine in vitiligo is interferon gamma, which is targeted by JAK1 and JAK2 inhibitors, but also JAK3 inhibitors, which will work more on IL-2 and IL-15, offer some good results. And then if we have diminished the immune attack, will the skin repigment of its own? Or do we need still some phototherapy or some sun exposure to get repigmentation? Now you will see in the trials that Dr. Wolkerstorfer will present that also monotherapy can lead to repigmentation, but often you will need sun exposure or phototherapy to get really good results for repigmentation. Of course, to make repigmentation possible, we need the melanocyte stem cells. And the melanocyte stem cells are located in the bult region, in the outer root sheath, and also down in the hair. There are also melanocyte stem cells in the epidermis and also in the eccrine sweat glands. But if we see that our hair is white, then we know the reservoir of these melanocyte stem cells is probably gone, and it will be very hard to get repigmentation. So always check if the hairs are white or not, because that will make it very difficult to treat the patients. One exception, you have in non-segmental vitiligo, it takes quite a while to get these white hairs, so always think of segmental vitiligo first, because that gives white hairs quite quickly. Also, in the hairs, think about alopecia areata, because that can also lead to white hairs and it's often associated with vitiligo. So for vitiligo, it's always the question how reversible it is, and that will depend from one patient to another. At this point, most drugs will try to stop disease progression, but nonetheless, the primary outcome of most trials is repigmentation. So it is in fact, a bit wrong to put this endpoint towards repigmentation when you only focus on the immune system, but nonetheless, that's the primary endpoint of most trials at this point. If we go to segmental vitiligo, the story is quite different. So segmental vitiligo is a somatic mosaicism, so there is a mutation in a melanocyte, and then the immune system gets active. So if we look at how melanocytes are formed, so they come from the back and then they will migrate and proliferate towards the front of the body. And there are a lot of proliferations there, so there's a high likelihood that there can be a mutation. And it's this mutation that the immune system will recognize and will attack. And that's why it has a lot of resemblance with other mosaic disorders like segmental lentiginosis. So this was a paper from a couple of years ago where our department showed that there is indeed an inflammatory response also in segmental vitiligo, and the same anti-melanocyte-specific cells are also present in segmental vitiligo, but only for a short while. This has been confirmed by other research where you can see that also in segmental vitiligo, the same immune markers like CXCL10 and interferon gamma are upregulated. So the same treatments during the active phase will work both for segmental and non-segmental vitiligo. So there we can offer the same options. So in fact, the segmental vitiligo has a lot of resemblance with other mosaic disorders like lichen sclerosus, where you have an active inflammatory phase followed by depigmentation. Now, if we look at which treatments are useful, we can focus on the melanocytes and on the T lymphocytes. So we want to stimulate the melanocytes and downregulate the T lymphocytes. So these are the topical treatments. So as you can see, only phototherapy is really useful to stimulate the repigmentation, while all the other treatments are focusing on downregulating the T lymphocytes. If you go to the systemic options, also there, not a lot of options to stimulate melanocytes, but now a lot of options to downregulate the inflammatory response. So we only have to look mainly at these two columns. And then we have several options. We can try to stimulate the melanocytes, for example, with UV treatment, but as monotherapy, it's not very effective. We can do the topical treatment to stop the immune response there. Usually that's the first thing we will try to do. For systemic options, where there's only one option to stimulate the melanocyte, I'm sure that Dr. Wolkerstorfer will talk about alpha melanocyte. And then now we have more and more systemic options where we have still a stronger possibility to stop the immune response. So always we will give the topical treatment. This topical treatment will not directly lead to repigmentation, but stop the progression. If we combine it with stimulation of the melanocyte, for example with UV treatment, then we get a lot more repigmentation. And now we have also the systemic options, and even the systemic options in monotherapy sometimes, probably with some UV exposure, like sun exposure, can also lead to some repigmentation. So what about future options? So of course the JAK inhibitors, you all heard about that. There are now a lot of trials that will start or are going on. So JAK1 and JAK2 mainly on interferon gamma, so the strongest one. But also the other JAK inhibitors will target interferon alpha, IL-6 and IL-12, which are driving cytokines, or IL-2 and IL-15, which are involved in the memory T-cell response. So it will be exciting to get the results of these trials, and Dr. Wolkerstorfer will already present some of these data. Now, what will be other options also? A JAK3 inhibitor, ritlecitinib, and we have the results, what it will do on the immune system. So here we see after 4 weeks and 24 weeks, there's a downregulation of T-cell activity, and that's exactly what we want to see. We know, like the IL-2 receptor, it's activated in active vitiligo, it's lower in stable vitiligo, and that's exactly what we see when we give ritlecitinib. So that's very good. Also the Th1 response, which is the most important response in vitiligo. When we give this anti-JAK3 inhibitor, it's downregulated, so perfect, that's what we want to see. We see also that the Th2 pathway is going down with anti-JAK3, which is not really necessary for vitiligo. Probably it will not cause a lot of harm when we downregulate the Th2 pathway. We know that from atopic dermatitis, and JAK inhibitors of course work also for atopic dermatitis. So we see there also it's going down. For vitiligo, it's not really on target, but probably will not cause a lot of adverse events. When we look at the Th17 pathway, that's unharmed. So more or less, it's a little bit specific that also anti-JAK3 inhibitor, it will leave the Th17 pathway at least unharmed. So we need other studies also for the other JAK inhibitors to know which pathways are downregulated or not, especially to get the results for the adverse events in the long run. So what could be other options? So with JAK inhibitors, we are downregulating interferon gamma everywhere. Of course, it could be a lot better when we do it only at the place where the attack of the melanocyte takes place. And that's the promise of the bispecific antibodies. So bispecific antibodies can bind to two targets. So for example, desmoglein, so on the keratinocyte, on the basal layer, and interferon gamma. So if you would have a biologic that can do this, we would only inhibit interferon gamma on the skin and not on the rest of the body. So very promising in the long run. What are other options? So you remember this protective layer around the hairs induced by these checkpoint inhibitors. So maybe we can upregulate these checkpoint inhibitors only on the melanocytes. And now also a treatment there has been developed where we have a PD-1 agonist binding on the melanocyte and forming a protective layer, some kind of igloo around this melanocyte to get this protection from the immune system. And finally, a last interesting trial which has been planned is about attacking the memory of vitiligo. So there we can have a biologic against IL-15. It is only in phase 1. Now phase 2 is planned, but we don't have any results on this yet, but maybe promising to really get rid of this memory in the skin. We can also try to improve the regulatory T cells by giving a low dose of IL-2. And so if we do this, we can also quieten the immune response. And now there are also trials, both in vitiligo and alopecia areata, with this low dose of IL-2, which will be coming. So a lot of different targets, a lot of different approaches. So really challenging and interesting time in vitiligo research. There are a lot of other targets, which I will not talk about because it's already as complicated as it is now. So main lesson here, we are very good in stopping the attack of the melanocytes, but not so good in stimulating the repigmentation. So now the question is, on what will we focus? Will we double down on this immune response like with JAK inhibitors and really try to get this handled and hope some repigmentation will take place? Or will we give a little bit of JAK inhibitors and focus on phototherapy, so we maybe have less adverse events in the long run? So that's a balance which we have to search now in the clinical practice. And I hope also the clinical trials will more focus on this aspect and not only double down on the immune system. Thank you.
Thank you very much, Professor Speeckaert. We propose to have the Q&A session at the end after the 3 presentations. And now Professor Van Geel is going to talk about international expert recommendations for the management of vitiligo.
Yes, thank you very much for having me tonight, this evening. I am pleased to speak about the worldwide expert recommendations for the management of vitiligo, which is actually an initiative that was performed together or in collaboration with the members of the International Vitiligo Task Force Group under the umbrella of the EADV. These are my disclosures, and maybe it's also important to mention that this is a consensus statement that was based on expert opinions, feedback from the patients that were also involved in this process, and also the published evidence at that time. But of course, we all know that guidelines need revisions over time, so they may override the current management recommendations so far. So this was an international initiative. As I mentioned, the Vitiligo Task Force was a core group, but we were also in connection with the East Asian Vitiligo Association and also the Vitiligo Global Vitiligo Foundation from the US, as well as a patient organization, the international one, VIPOC, and other international participants. It was actually also based on an update of the previous guidelines that were on the European level and published in 2013 under the lead from Alain Tayeb and Mauro Picardo. However, these are the first international global guidelines or recommendations, and all continents were actually involved. So previously we had only the local Japanese, British and German guidelines, but also these European guidelines. All these organizations are previous members of the guidelines of other countries who are involved in this global recommendation process. So this initiative started several years ago, and at the basis we composed several working groups per topic. And at the beginning of this process, we also decided to keep it as an S1 level, so an expert-based recommendation, although we all know that currently we would like to prefer to use the specific recommendations to compose guidelines according to other criteria or methods. For this process, we had writing groups involved, and these were composed by, or it was a collaboration of 42 international vitiligo experts, and also 4 vitiligo patients representatives were involved. Yeah, we had a lot of email correspondence, but also a lot of meetings all together, online, live, and we all looked to the literature that was available at that time. So in 2023, we had, for instance, 3 vitiligo task force meetings. We had a revision time. We also had a survey including remaining issues that could not be solved. Then there was a specific devoted meeting during the VIPOC meeting, so the patients organization meeting in Amsterdam in 22. And then in August 22, we had a draft of the paper of this manuscript. And finally, during the EADV in Milan in September 22, we had also a consensus on all the remaining issues. And all the recommendations were finalized. So consequently, this could be published, and this was in September 23. And you can see here that the recommendations that are divided into 2 parts. So the first part is focusing on the diagnosis and the management algorithm, while the second part is focusing on specific treatment recommendations. So in the first part, we have more information about, for instance, the diagnosis terminology, the severity methods, assessment methods, but also the general remarks in the context of treatment recommendations. So it's a really practical approach. In part 2, more information related to the specific treatment options are explained more in detail, like, for instance, the topicals, but also phototherapy, and also systemic treatments or other treatment options. So first of all, in part 1, the algorithm was included, and I think the algorithm plays a key role in this paper because it's explaining actually everything in one slide. And we composed 2 algorithms, one for vitiligo, so non-segmental vitiligo, and also one for segmental vitiligo. In the algorithm, 4 levels are distinguished, and the first one is focusing on diagnosis, the second one on the shared decision making, the third one on the assessment of disease activity, and the 4th level is the treatment choice, as you can see also here. So first of all, step 1 is to make your diagnosis, and we would like to emphasize one more time not to forget to distinguish the non-segmental form from the segmental form. So the segmental form, it's a typical unilateral distribution, as you can see on this picture, while the non-segmental form has a classical distribution. And segmental vitiligo is also characterized by early stabilization, so within 1 to 2 years, which is of course important for the prognosis. Within the guidelines and the recommendations, we also decided to use another term. So instead of the umbrella term that was decided to use in 2012, it was decided to use the term non-segmental vitiligo for all segmental vitiligos except the segmental form. So within this non-segmental vitiligo, we also include, for instance, mixed vitiligo. Mixed vitiligo is a more recently described entity in which we can see both the non-segmental and the segmental form. In the second step, there was a lot of attention for shared decision-making. And this was also important, especially because our patients were involved within this process. So they also appreciate this second step. And I think nowadays this is more a commonly used way to go to a treatment decision. So for the treatment shared decision-making, we focus on the treatment goals. First of all, patients would like to focus, for instance, on stabilization, repigmentation, or some patients are asking for depigmentation therapies. In the shared decision-making, we also speak about the prognosis. What can they expect also from the treatment outcomes? Important to mention is also the pros and the cons from each treatment, and also to pay attention to disease impacts. Also for the treatment, the assessment or prognosis for treatment response, the assessment of disease activity as well as lesion locations are important to make your predictions. We all know that some areas react much better than other areas. Also, other issues can be important, like skin type or disease duration. In general, we need to remember the specific approach of our patients, and the physician should really recognize the importance of the disease. We also should offer information of psychological support if this is indicated, and we need to provide information, for instance, in the form of a leaflet. It's also important to inform them about support groups or vitiligo patients organizations. Within the third level, which is actually a key element and new in the guidelines, is the assessment of disease activity. Disease activity plays a key role in the decision-making now. So for the disease activity, we are concentrating on the previous 6 months for the commonly used treatments, and in case of surgical treatment on the stability for 12 months. For the clinical evaluation of disease activity, it's important to know that there are 2 possibilities for the assessment. So the assessment can be based on picture evaluation to assess dynamic changes over time. However, more recently, more attention has been paid to this static assessments based on vitiligo visible signs of activity. Also, for the dynamic assessments, it's important to take pictures for the follow-up and to do your comparison. Within this context, we also composed recommendations on how to take in a standardized way pictures in vitiligo. This was also published together with this international group. Within this publication, we describe how to take pictures, for instance, for clinical practice in 10 areas, but also for clinical trials, which is in more detail. Within the publication, you can find also other interesting information on how to do your standardized photography. For instance, related to the positioning of your patient, but also the lighting that can be used, UV photography, for instance, but also some recommendations on the camera, how to use it, and the settings. Also for the positioning, we included some examples for the feet, for instance, and also for the camera, how to take your pictures. So related to disease activity signs, as I mentioned, this has more attention right now, specifically also in trials, because at the beginning of a trial in a clinical setting, the new medical trials, they do not always have pictures or the evolution before the start of the treatment. And therefore, they also rely on these static signs. So it's a single time point evaluation. So within a meta-analysis, we could demonstrate that specific clinical signs of disease activity were related to vitiligo activity and changes over time. These 3 signs are confetti-like depigmentation, Koepner's phenomenon, and hypochromic areas/borders. Most promising in the prediction of disease activity is, in our view, the confetti-like depigmentations. And this is actually also more easy to recognize. As you can see on these pictures, this is characterized by these tiny little depigmented spots. Within this context, it can also be important to know where these signs are present. And this is actually the work of our PhD student, Lisbeth Delbare. She looked to the predilection sites on the body of these signs and could show that for confetti-like depigmentation, they were mainly present on the elbow. For Koepner's phenomenon, they were mainly present on the hands, and hypochromic areas were mostly present in the axilla. She also performed some analysis on the prediction or the probability of these signs to have actually a disease activity over time. And important to mention was that in her prediction model, she could also demonstrate that the simultaneous presence of multiple types of activity signs or the presence on 2 or more locations could increase the chance of actually having an active disease to 94%. To do your assessment of disease activity signs, we constructed and validated more recently a standardized scoring system, which is Vitiligo's sign of activity score. This new scoring system is also included now in the website, the Vitiligo calculator, which actually includes also other scoring systems like the Vitiligo Extend Score, Vitiligo Extend Score Plus, and the self-assessment Vitiligo Extend Score. This Vitiligo sign of activity score can also be found in this website, as you can see here, where you could see on each area the 3 possibilities of selecting the signs. For the evolution in time, we also have now a validated score, which is the Vitiligo Disease Activity Score, which is a possibility to use to make a standardized registration of the evolution in time. This is actually a scoring system that we commonly use now within our clinical practice. This is a very simple tool in which you can indicate the improved areas as well as the active lesions on the body on 15 areas. Within the recommendations, the guidelines, we also included a specific checklist that can be helpful in your clinical practice. We are focusing there on patient characteristics, so for instance, the photoskin type, but mainly also on disease features like the type of vitiligo and also the disease extent, the location of the lesion. So these are all possibilities to include in your clinical assessment during your consultation. We also included the evaluation of disease activity, as it is a key element right now. You can find also this checklist in the paper that has been published. Within the paper, we also explained some possibilities of using specific scores, and we all know for extent there are several scores now. For impact, we have specific scores, and however, there is still no consensus yet on which score to use, or even on which outcome to assess, for instance, in each trial, or for instance, in clinical practice. So this is actually also the reason that there is now a currently ongoing trial that is focusing on having a consensus on these issues. And this is actually the work also in which our other PhD student, Jolene Duponcelle, is involved. So we hope with this international initiative to have a consensus on how to measure vitiligo in the future. Within the publication on the recommendations for vitiligo, we also mentioned a routine screening for the thyroid disease. So we recommend to screen for the anti-thyroid antibodies and thyroid function. So for the treatment, so this is the 4th level of our algorithm. We mentioned the different options like topical treatments, but also the phototherapy, systemic treatments, surgical interventions, and depigmentation therapies. So some general remarks that are important in the context of treatments. So we all agreed that the detection and treatment of vitiligo at the early stage was essential for an optimal management. We also all agreed that active vitiligo needs topical treatment or phototherapy, and if rapidly progressive, even the option of systemic treatments. The combination therapies are considered as being more effective. I think we all know this nowadays. And we all agreed that for the topical treatments that the topical steroids as well as immunomodulators can be considered, but they can depend on the location of the body. In general, we all agreed that evaluation of treatment response should be performed in case of phototherapy every 3 months and for topical treatments every 3 to 6 months. In the context of surgical treatment, we also agreed that the vitiligo should be stable for at least 12 months without any treatment. In the context of depigmentation therapy, it was also agreed that therapy-resistant extensive vitiligo could be considered for this option, but also in sensitive or visible areas only. For instance, if the face is depigmented for 80%, you could consider, even in this specific area, the depigmentation therapy, if this is a question from the patient. There is also specific attention related to the maintenance treatment that should be considered to prevent relapses. And in this context, I would like to emphasize that we know that there is a high relapse rate after discontinuation of treatments. There was a study demonstrating that even 44 of the patients showed a relapse in the first year after discontinuation of treatment. Another study could demonstrate the value of using a bi-weekly application of topical ointments in the remaining, so in the decreasing the relapse rate. So the optimal duration of the maintenance therapy is not yet defined, although we all agreed that 6 months is a good consideration. So within the treatment options, you can also find the other options like phototherapy and systemic treatments. Within the context of systemic treatments, at that time, mostly published or used so far were the oral steroids, mini-pills therapies. This is supported mainly by investigators, our colleagues from India. But of course, we all know that we have now news about the new treatments that will be explained in the next presentation by my colleague Albert Wolkerstorfer. Related to systemic steroid therapy, a lot of attention in the literature was paid to oral mini-pills therapy, in which a treatment on 2 consecutive days is recommended. Of course, you need to consider for these treatments the risk and benefits ratios. And this should not be, if this in the context of mini-pills therapy, they recommended not to go for more than 3 months or a maximum of 6 months. The last option mentioned in the algorithm for treatment was depigmentation therapy, including monobenzyl ether, pigment laser, or cryotherapy. There was also there were some questions about how to define a rapidly progressive vitiligo. And at that time, we decided to compose, together with a focus group of patients representative, a temporary or tentative definition, in which it was defined that the rapidly progressive vitiligo is defined as vitiligo in which a large number of new spots or a significant enlargement was seen over the past 3 months. However, these are difficult definitions, and this is actually incorporated in a new project that will start with the name Active, also in combination or in collaboration with the same group. Related to segmental vitiligo, I will not go into detail based of lack of time. The only thing maybe to mention is that there are some other treatment options and that can be considered in an earlier stage, like the surgical technique, specifically in the context of presence of leukotrichia. We all know that these areas are very treatment resistant, and then these surgical treatments can be considered. So in conclusion, I think the main key messages are, take-home messages are the following. So we need to use the term non-segmental vitiligo instead of the umbrella term vitiligo from now on. We also highlighted the importance of the shared decision-making. The assessment of disease activity is really a key element in your management, in your decision-making. Early detection and early, even aggressive treatments are essential for an optimal management of the patient. You also need to think to offer psychological support and provide information. Related to the treatments, we all know now that combination treatments are in general more effective. For the topical steroids, we also know, and for the topical immune modulator, for the topical steroids, we also recommend an intermittent regime. I did not mention that before, but to avoid, of course, the side effects, for instance, 2 weeks off, 2 weeks on. For the topical immune modulators, we mentioned also the twice-daily application, or I mention it now, twice-daily application that can be used for 6 months. However, the maintenance regime was mentioned, in which you can think about a bi-weekly application of topical immune modulators. Narrowband UVB therapy should be evaluated after 3 months. The steroid menopause therapy was suggested or included in this recommendation. However, of course, we all know that more promising or possible more promising treatments are on the horizon, like the topical ruxolitinib, that is now also the first FDA and EMA approved treatment, as well as all the new ongoing trials related to systemic JAKs that are important to remember. I hope that they will be available in the future. One other thing to inform you about, this is next week we will have the Vitiligo, World Vitiligo Day, which is on June 25. And I would like to finish and thank you all, and also specifically our Vitiligo research team. Thank you all for listening to this presentation.
Thank you very much, Professor Van Geel. Now, Professor Wolkerstorfer will focus on new treatments of vitiligo, and in particular on JAK inhibitors. Unfortunately, Professor Wolkerstorfer is not present with us, but he has prepared a recording for tonight, but he will be there just after in live to respond to all questions.
Good evening, ladies and gentlemen. I'm Albert Wolkerstorfer, dermatologist in Amsterdam at the University Medical Center. And I'm going to talk about new treatments for vitiligo. First of all, here's my conflict of interest, of which one with inside MSD or EPFI might be relevant to this presentation. Now, we treat vitiligo because of the psychosocial impact. Some call it the dark side of the white patches. So appearance does matter, but there are also issues with the unpredictable flare-ups, with itching and association with other autoimmune disorders. Unluckily, treatments are not yet very effective as in psoriasis or eczema, and therefore we do need new treatments for vitiligo. And I'm going to give a short introduction, talk about the pathogenesis and about the new treatments. Now, if we want to treat vitiligo, above all, we need to address the inflammatory component. And there are several treatments that we already have at our disposal today. We also want to address the melanocyte and stimulate its proliferation and migration. And sometimes we also need to actively transplant melanocytes into the depigmented patches. And of course, we should not forget psychological support for our patients. So, let's look more closely at the pathogenesis of vitiligo, and it all starts with a certain genetic predisposition and probably oxidative stress that will trigger the innate immune system, and interferon gamma will be produced. And in this context, heat shock proteins are an important part in the initial stage. Finally, this will trigger the adaptive immune system, and many different immune cells, but also receptors and cytokines are involved in triggering this immune response, which is quite complex and finally will lead into the destruction of melanocytes. Now, I would like to divide the drugs into those that will address the initiation stage, those that will work on the inflammatory stage, and those that might address the melanocytes directly. So in the initiation stage, heat shock protein 70 has been shown to be important, and an inhibitor of this molecule has found to be effective in a vitiligo mouse model. Another interesting substance are antioxidants, and there's controversy about them because there have been many studies with controversial results, and only recently there were some trials showing efficacy in a more sustained way. And this is a study that was published 3 years ago by the group from Nice, where they showed in a nice randomized controlled trial that when an antioxidant was combined with narrowband UVB, the outcomes in terms of repigmentation was much better. The most important approach is probably to address the inflammatory component. And as this is a very complex process, there are many potential targets for biologics to address vitiligo. Most of these are yet in a preclinical stage, but I'm sure we can expect in the future treatments based on biologics in vitiligo. At the moment, JAK inhibitors are a well-established way to treat vitiligo, at least one topical that has been already approved by the regulatory authorities in the US and Europe. And later in my talk, I will specifically address these groups of drugs. The melanocyte is, of course, another potential target for new treatments. And alpha-melanocyte has been introduced already years ago, which is a variant of the alpha-melanocyte stimulating hormone, and which had been introduced into an implant that has to be implanted into the skin and that will slowly release the hormone over time. There was a very nice study published in JAMA Dermatology where they compared narrowband UVB to narrowband UVB plus the alpha-melanocyte, and they did show efficacy or a higher efficacy of the combination, about 20% more repigmentation. However, patients were not really so satisfied, as due to the effect of the alpha MSH, there was a very strong pigmentation of normal skin, so the contrast increased dramatically, which is not very appealing to patients. A very interesting approach to target melanocytes are SYK inhibitors. these are small molecules that directly interfere in the pathway of melanin synthesis, and they can increase the expression of MITF, which is the master regulator gene of melanin synthesis. So in a very nice study, the authors showed that these Syk inhibitors, both in vitro and in a mouse model and in human skin explants, were able to stimulate pigmentation. Of course, it will still take many years before this may enter into the clinics, but it is a great way to induce natural pigmentation without any UV light. And the last approach to target melanocytes is the one with Wnt agonists. And this is interesting because the Wnt pathway has been shown to be involved in the regulation of major genes for melanin synthesis like MITF and tyrosinase. So again, this would be an approach to stimulate a natural pigmentation without the use of UV light. Now, having talked a lot about the different potential treatments and approaches, JAK inhibitors are special because there's quite a lot of evidence already for their efficacy in vitiligo. So I will focus on this. And it all started quite some years ago when the group of John Harris found out that the interferon gamma pathway is crucial in vitiligo pathogenesis. And it is also clear that the JAK-STAT signaling pathway is involved in regulating the effects of interferon gamma. The first JAK proteins were identified in 1989, and at that time nobody really knew how important they were. So they were called just another kinase, JAK1, JAK2, and that's how the name JAK came into being. Only later, when it was realized how important they were renamed into Janus kinase, according to a Roman god that was very important at those times, as it was the god of duality that often was shown with two faces. Now today, JAK inhibitors have been approved for various indications in the field of medicine. And in dermatology, of course, atopic dermatitis and alopecia areata are the most well-known ones. Now, the JAK-STAT signaling is essential for various cytokines and even some growth hormones. And the effect is transduced finally into changes of gene expression through this JAK-STAT signaling pathway. So it's a very important signaling pathway in human life. There are quite a number of JAK inhibitors already, but in vitiligo only 5 JAK inhibitors have entered phase 2 or phase 3 studies. And they all are rather small molecules, between about 300 and 400 gram per mole. And as you can see, ruxolitinib is one of the smallest, and it does make sense that this is a topical formulation, while the other ones are systemic formulations. The JAK inhibitors for vitiligo target different JAK molecules, and it is, however, not yet clear which is the best target and whether this really makes a difference in terms of treatment outcomes. As you can see, there are 3 of those JAK inhibitors that have entered a phase 3, and one of them, ruxolitinib, has a finished phase 3 study and is already approved in Europe and the US. Most of the studies with JAK inhibitors compared monotherapy to placebo. Only one of them, baricitinib, combined it with narrowband UVB. And one of those is now already, as I said, on the market in some European countries and in the US. And so I'll start with ruxolitinib 1.5% cream, which is a milestone in vitiligo treatment, as it is the first approved drug for repigmentation in vitiligo. So in fact, everything what we are using till today has no official approval. And the studies with this drug gave us studies of very high quality and were published in Lancet and the New England Journal of Medicine. Here you see the study design of the phase 3 study with about 700 participants who were randomized to placebo or the Rux cream. And this is probably the most important outcome. The primary outcome measure was the percentage of patients achieving more than 75% repigmentation in the face, what we call the F-FASI 75. And as you can see, at week 24, about 31% of the patients achieved this threshold, and after 52 weeks, 50.3%. And what we also saw, because there was an extension period for about 2 years, that with continued application also the repigmentation improved. And what we also learned from that large study was that even the patients that were non-responders at week 24, so after about 6 months, if they continued the application, they still got substantial improvement in their vitiligo. So I think this is something that we learned from this study, and that where we didn't have any evidence until now. But what we saw in this study was that repigmentation is really slow and recurrence happens when you stop the treatment. The second JAK inhibitor I want to talk about is ritlecitinib, that was studied in a phase 2b study. And here you can see the dose finding that was done with different doses. And here you can see the outcomes in terms of repigmentation. And what you can see is that at week 24, not so much happened. The higher doses gave somewhat better results in terms of repigmentation. The placebo and the lower doses did not. But after week 24, all of a sudden, the improvement begins to be more consistently over the whole group. And there is continued improvement up to week 48. The next one I'd like to talk about is baricitinib. And this was the one that was studied in combination with narrowband UVB. It is a JAK1, JAK2 inhibitor, just like the ruxolitinib cream. And here you see the study design on the left side. So they started first with 3 months of baricitinib versus placebo, and then combined it with narrowband UVB during 6 months. So after 9 months, they looked at the outcomes, and they saw that the total FASI increased by 44%, which is a very good result for 9 months of treatment. The next one is povorcitinib, a JAK1 inhibitor that has a completed phase 2b study and now just entered a phase 3 study. Here you see the phase 2 study and the dose finding that was done with 3 doses versus placebo, and then from week 24 on only 2 doses were used. And what you can see here is again a very slow improvement over time with the higher doses in the end giving a better outcome. And this is very consistently, as it seems, over all the JAK inhibitor studies, that it takes a long time before we see repigmentation. Here you can see the outcomes, and again the facial VASI 75 was 45.5% to 58.66%, depending on the dose that was used. And the last one is upadacitinib, and again a phase 2 study was completed and a phase 3 study is going on. Here you see the phase 2 study, again dose finding versus placebo, and again you see improvement that is continuing over time, and at week 52 again about 45 to 50%, depending on the dose, achieve a result. Another important thing about JAK inhibitors is the warning about their side effects. And this is a warning for the whole group of JAK inhibitors concerning major cardiovascular events, venous thrombosis, and in general serious adverse events. And it is now very reassuring that in dermatological studies, and there are now 45 eligible RCTs that entered this meta-analysis that was just published a month ago. And what we see is that in those studies, more than 12,000 patients were included, and compared to placebo, that there were no significant differences either in the major cardiovascular events or venous thrombosis or serious adverse events in general. So this is really very reassuring for using systemic JAK inhibitors in dermatology. So my take-home message is that there are many drugs in development for vitiligo, and this is easily explained by the complex pathogenesis of vitiligo, with many points of actions and targets for treatments. Especially the inflammatory component can be treated by many antibodies and maybe also small molecules. The efficacy probably still will depend on the location, as we know for all other treatments until now, and also prolonged treatment duration is necessary. And with regard to JAK inhibitors, I think we can state that they are a milestone in vitiligo, that there is enough evidence to conclude that they are effective and that topical JAK inhibitors are safe. Also on longer term, efficacy probably again will depend on the location, and prolonged treatment durations are necessary, and even non-responders at 6 months still improve when they continue the application. And probably to get a quicker response and better outcomes, combination with phototherapy will be necessary in the future. So with this, I'd like to thank you for your attention.
Thank you very much to Professor Wolkerstorfer. We have now time for some questions. I already received some questions. The first one concerned the segmental vitiligo. What are the current therapeutic options? I think you have already partially responded to this question.
Yes, so for segmental vitiligo, we need to take into account that there is a different evolution than in non-segmental vitiligo. So you can expect that there will be a spontaneous stabilization within 1 to 2 years. But it's also mainly based on clinical experience, actually, that the early treatment, specifically in segmental vitiligo, is important, because you can also see more often leukotrichia, which is more resistant to any treatment. So to stop the progression, you should treat as early as possible. However, we also know that the segmental vitiligo is typically also characterized by very quick rapidly progressive phase at the beginning of the disease. It's already, most of the time, we miss this stage. If we see the patients, the vitiligo is already there. And so the early stage, it's more exceptional to see this early stage. But this would be the best timing to do the treatment. So the type of treatment in the early stage could be the topical steroids or topical immune modulators. However, you could also consider local phototherapy or excimer laser therapy, for instance. Most of all, I think we all agreed now that this type is the best form to consider surgical treatment. So at the end, segmental vitiligo is very treatment resistant to the classical treatment, so then we end up with surgical treatment. Surgical treatments are nowadays recognized as a good option, however, not for non-segmental vitiligo, and it's also not available in a lot of centers right now. So it's more complicated. Yeah.
Thank you. There is also a suggestion about PRP. Is it useful or a possible option for, in this case, non-segmental vitiligo?
There are not really a lot of studies on PRP really showing a consistent efficacy. So, yeah, the only thing it could do is give some stimulation, but there are not really good results on that. And so that's not really good efficacy that it can stimulate melanocytes to come back. So, yeah, there are not really a lot of data that, and I would be surprised that it would be really a good option, to be honest.
There is a question about the labo test results. I think it was you, Professor Van Geel, who speak about this. What is the clinical relevance?
Yes. So we all know that in segmental vitiligo we have a higher risk on thyroid disease. So in our center, for instance, this is around 10 to 13% of our patients. So it's really important to screen for this. All other autoimmune disease should only be screened for if there are clinical signs or other augments to do this, but not on a regular basis in our view. So we recommend the thyroid function, so TSA, and also the anti-TPO at least to do to also make a prediction for the future. So if this is all normal, we do not redo this in the future. If the anti-TPO is demonstrating a higher level, we recommend to re-evaluate in 1 year, if this function is still normal, of course.
Thank you. Question also more practical about which dose of Medrol do you give, for how long, and when do you give it? I think last part you have already responded, but maybe the dose and the...
Yeah, it depends a bit on the center. To be honest, these are data from India. We don't use it a lot. So it's only 2 days a week. Like it's a Medrol dose of 16 milligram, approximately around that, I think, for 2 days in a week, and then for 3 to 6 months. Yeah, you can stop at that point the disease progression with the intention then to go forward with the topical treatment. Now, it's really short, and vitiligo is a long-term disease. So it's a difficult one. I'm not a big fan of giving that for such a short time because the disease will recur after a while. So it's still in the guidelines, but I think we will soon have far better options than the mini-pills.
Within the guidelines, it was also mainly included to stop progression. So in very progressive forms of vitiligo, it was recommended, but based on just also some data we have so far. But I agree that in the future, I think we have other solutions or options. Yeah.
Thank you. I have maybe a question for Professor Wolkerstorfer. You know that children are sometimes also affected. What about children and this new therapeutic option? Do you have some?
Yeah, so that is of course a very good question, and we in children we are always more reluctant to provide new treatments where we don't have so much clinical data. Of course, we have to mention that the ruxolitinib cream is now approved from the age of 12 years on, and there are studies now being planned even to investigate from 6 years on. And I think that's a good thing because we need to treat early, and we don't have maybe that good treatments in very young children. For example, narrowband UVB, we typically start at the age of 8 years, but we are always kind of a conservative in prescribing narrowband UVB in children, of course, depending on the extent of vitiligo, the progression, how progressive it is, and of course the skin type also. So in children, yeah, we are a bit limited, certainly in the very young children.
Thank you. We also have a lot of questions about access to those molecules. We will heard you about experience in the Netherlands, and maybe Reinhart
The problem is, of course, the
could speak the...
Yeah, you can get a topical ruxolitinib, but at the moment it's, I think, around 900 euro for a tube of 60 gram. So it's very expensive. I have some patients which are willing to pay it because they are desperate. But yeah, we are really hoping there will be reimbursement. I think we will know it at the end of the year, beginning next year. There are now reimbursements in other countries around us, so hopefully we will follow, because that would be a major breakthrough for vitiligo. Because now we know it works, but it's just way too expensive because you need it for a long time. It's not for 6 weeks or half a year, it's for 1 to 2 years. Then you see the real improvement there. So at the moment, I think still too expensive to give, but if we have reimbursement, it would be for sure a good option.
Do you already have reimbursement in the Netherlands for the cream?
No, we are working on it, but in Germany, Austria, and now France is the third country where reimbursement is going to happen. So I think over time this will certainly come in more European countries. But at this moment, I do have patients who I prescribe it and who go to Germany and get their ruxolitinib cream. I do not actively advise that because it is very expensive. And actually, we don't have head-to-head comparisons. So we don't really have the direct comparison to the topical corticosteroids or to UVB or to the calcineurin inhibitors.
And between cream and oral JAK inhibitors?
Well, at the moment, it doesn't seem to be such a big difference, which surprises me actually. Although there is also a difference in population, because in the Rux cream study, the maximum extent of vitiligo was 10%, and in the studies with systemic application of the JAK inhibitors, often the extent was larger, like 20%, or some even have 50% as a threshold. So this might be different populations we are looking at, but the data at the moment are not so very different. So I find this quite surprising.
Yes, of course.
We also treat only one component of the vitiligo, which is the immune system. But we need also stimulation of the melanocytes. So now there are some trials to do the combination, for example with baricitinib, and there you see a lot of repigmentation. Of course, we will have to wait for the longer term data there. But yeah, with JAK inhibitors, it's only the immune system which will stop the progression for sure. But for the repigmentation, as we can see, it takes a lot of time because we don't do any active therapy there. Yeah.
Yeah, I think, sorry if I may comment to that. I totally agree. And I think the difference is between the face and the body, that on the face, the daylight exposure probably stimulates also quite a lot. And therefore, even without UV light treatment, we do see very good results. But on the body, so off the face, the results of like topical corticosteroids is really poor. it's more for stabilization and not very well for repigmentation. I was quite surprised that ruxolitinib cream did quite well also on the body, certainly by far not as good as in the face, but I agree we do need stimulation of melanocytes, whether this is UV light, maybe even visible light. There are now quite also some data that blue light has a stimulating effect on melanocytes and on melanin synthesis. So maybe we have to reinvent phototherapy also. Now we have very good treatments for the inflammatory component.
We have also a question from a colleague from Africa in Congo. He or she said, we do not have access to new molecule from the treatment of vitiligo, only corticosteroids and meladinin. How can we get by with the old treatments? We have, I think, already response, but...
I think already with the topical corticoids, you can have a good effect. You just have to explain it to your patients. Don't expect a full repigmentation directly. You have to do it for a long time. At least you can stop the progression. And with time, especially in the face, you will notice an improvement. Yeah. Mm-hmm. And for the meladinin, yeah, of course, we don't like the PIVA like previously. I know in some countries, especially when they're in the tropical countries, they like to give some photosensitizers. Of course, they have a different skin type because in Caucasian patients we don't like it because then we would induce skin cancer. Yeah.
Okay. And also a more practical question, where in Belgium is surgical repigmentation therapy available? Do you maybe have some...
Yes, unfortunately, we performed the surgical techniques in the past, but unfortunately, for now it's on hold. So we are looking for solutions to restart. I know that in Amsterdam they still perform the procedure, and sometimes we are now also referring the patients to my colleague Albert in Amsterdam. Yes. But we hope that it's in the future we can restart that. Mm-hmm. We are now currently also looking for the options and discussing this. So hopefully. Yeah.
And to return to the local treatment, how long can you give the active local treatment? You speak about weekend therapy. I think it's...
Yeah, the intermittent therapy is for local steroids really necessary to avoid the atrophy in the long run. Mm-hmm. Of course, when it's stable, you can wait and try to give the skin a bit of rest from the topical steroids. From the topical immunomodulators, like tacrolimus and pimecrolimus, you can do it once daily for quite a long time. Of course, when it's stable, you can go for the maintenance, like twice weekly. But there's not a fixed term when you have to stop, in fact. Of course, when it's very stable, you will always try to stop and see what happens and really get good pictures. That's very essential, get good pictures and make the comparison. But there's not a really fixed time frame when you have to stop. Of course, it depends from one patient to another. If you have a patient who is prone for atrophy, of course, or a child which is growing, of course, then you will make a more precise decision when to stop, of course, and not give that strong steroids then.
But one very important message also from Professor Wolkerstorfer is that it can really take time, that it's really, it's incredible that sometimes you don't see anything until 6 months, and it's just after that. I think it's really important for patients, and as Professor Van Geel said also, the picture. I think it's really important to take picture and to show to the patient, see there is a difference. Maybe you see it every day, you don't really see a difference.
Yes,
but,
the pictures are really important for your evaluation. And we also take specific pictures with UV light, because if you take normal pictures, it's very difficult to see the vitiligo in fair-skinned people. So we prefer to use UV photography. And also our experience indeed that you really need to continue with treatment, topical treatments, at least for 6 months to decide whether it's effective or not.
Yeah, because in the first 2 months you don't know. Yeah.
I think we often see patients who come to us and say, well, I tried the topical treatments. I used them for 4 or 6 weeks and they didn't work. So I think that the lack of information is really the thing that makes the treatment not work, or even make it not possible to work at all.
Thank you very much. Unfortunately, it's time to close this really interesting discussion. Thank you very, very much to our 3 speakers. Thank you very much, Professor Wolkerstorfer. A great thanks also to Jennifer from the Belgian Society, to our president, Professor Delmar Moll, and a very big thanks again to all sponsors who are absolutely necessary to have such very interesting webinars. Thank you very much and have a good night.